So we'll move on. And this is my summary slide for those of you who want to have a little sleep before lunch. We will come back to this at the end. We've had some progress in renal cell, most particularly with exitinib, a drug that's now available and approved by the FDA in the second line, demonstrating a median progression-free survival of 14.5 months in the first line, as long as we've seen, and I think potentially significant, suggesting it's a powerful agent. We don't really have definitive data in the first line yet with it, however. I'll show you a little data on tivozanib versus sorafenib. Tivozanib's here, and the advantage of tivozanib, if we look at the toxicity data across trials, which is dangerous, is that it may produce less long-term diarrhea. We're going to have to see. And we've got a new agent that you've heard a little bit about in some of the other talks called PD-1 or anti-PD-1, anti-program death 1, where that may be an easier immunotherapy for us to use. In prostate cancer, we had a lot of action. And as one of the co-investigators on 9346, the SWOG study of intermittent androgen deprivation therapy, I'd like to apologise to you that the data is so complex, and we'll take a walk through that. We've had some data that helps us refine the use of immunotherapy with Sip-T, data on Abiraterone before docetaxel, MDV 3100 enzalutamide after docetaxel, and some liquid radiation that actually improves overall survival in castrate-resistant disease. We had some data on cabozantinib, a dual VEGF receptor and MET inhibitor. I won't talk much about that, but it is moving into phase 3 trials. The urothelial cancer and germ cell tumours, nothing practice-changing this year, and not much on the horizon. There's a trial that I'd alert you to of something that targets heat shock protein 27 in combination with gemcitabine and cisplatin for first-line metastatic urothelial cancer that you should try and enroll patients on, because the preclinical and also phase 1 data look very promising. But I've said that before, and we've ended up with a blooper. So that's the summary. For those of you who wish to go to early lunch or have a sleep, please go right ahead. So we had this hiatus in the development of prostate cancer therapies after docetaxel here in the middle. And to the left, this is all old news. But a 6-year gap. Why did we have that? Well, people proselytise, not even the ones that are up here on the microphone, and they said to me when I was running a trial of an epothelone in the first line after docetaxel got licensed, you must give docetaxel first line, or otherwise you're not giving standard of care and you should go to hell. And I said to them, I will go to hell if you can tell me that I'm curing the patient with no side effects. I'll gladly go to hell. And from that perspective, there was a hiatus where we didn't think for about 3 years after docetaxel was licensed, and we did studies, and I did one of them, which I won't talk about too much because it doesn't practice change, where we tried adding stuff to docetaxel. Docetaxel is the black widow for trying to put stuff with it. Does not marry well. Marries well but kills its mate. From that perspective, some people said it's not the black widow, it's the praying mantis, because the praying mantis actually not only kills its mate, it eats it. So but whatever. And so it took us a while to have some new stuff. We got a new chemo first, cabazitaxel, and then immunotherapy, some more bone-targeted stuff, and then a couple of new hormonal agents that I'll talk about, and most particularly more recently, and perhaps most excitingly, radium-223, which is a relatively low toxicity liquid radiation nuclide therapy that actually improves overall survival. So this is our sequence of patients, and remember that most of the patients don't actually get to us. The sequence here is important because when a patient develops clinical metastases, they have a 50% chance of dying of prostate cancer, roughly. By the time a patient becomes castrate resistant and they have metastases, that increases to 98%. So the guys we're looking at with castrate resistant disease, they're going to die of their stuff. Now, it may improve as we stretch out with some of the new therapies, and we may actually stop them from dying of prostate cancer to have them die of something else. a Pyrrhic victory, and hopefully improve their quality of life. But we've developed a sequence now where we cut up the castrate resistance space into sort of early or pre-docetaxel where the patients don't have many symptoms. Docetaxel is still an important drug in the middle, and then post-docetaxel therapies that some of which we hope to bring forward to be pre-docetaxel and even with first-line androgen deprivation therapy. So that's the setting. This study was on the plenary, intermittent versus continuous androgen deprivation in hormone-sensitive metastatic prostate cancer. It was a phase 3 trial started by Maha Hussein when she was a junior assistant professor at Wayne State in Detroit. She's now a full professor at the University of Michigan, and this trial was written in 1993 and is only now just being presented, so spans her career. And the results are interesting. I will walk you through it. So the background here is that SWOG did 2 prior studies that looked at the role of flutamide with leuprolide and with orchiectomy, and showed variable results with at least a trend to overall survival improvement. And the reason for putting this in is actually to look at these figures. The overall survival here ranged from 28 through 35 months. With the other ones inside that. So that was our sort of survival of 2.5 to 3 years as a median, and it was something that we took forward in the design of 9346 to try and power that study. Now, in this particular study design, we took patients that had metastatic disease at the get-go. They had to have a PSA of more than 5, and they're allowed 2 pathways, either early registration. So they had metastases, they were starting hormone therapy, they were registered, and they went on to the combination of gaserelin and baclutamide for 7 months. They could also register late, so if they'd started other therapy, they could go on, provided they hadn't got beyond the 6-month mark. And this was to augment accrual, and most of the patients who went on with late registration were on by 90 days. So the patients then proceeded, and if their PSA got to less than 4 in months 6 and 7, they were then randomly assigned to continuous androgen deprivation or intermittent. If they were above 4, they were taken off protocol and followed, obviously with androgen deprivation, but also potentially some other therapies. At the time the study was written, there was no standard therapy for these patients to be treated with. Intermittent therapy, there was discontinuation, and then monthly PSAs and a resumption of androgen deprivation based on pre-specified criteria. Either the patient's prior PSA or a PSA that hit more than 20 were mandated. If they got symptoms, they're also meant to go back on therapy. The physician could also decide to put them back on treatment. So that was not mandated. We did not measure testosterone because it was not funded by the government in their wisdom. Now, I mentioned the patients where their PSA did not go to less than 4. Well, we published on this previously, and these patients do badly. If you look here, this is the survival. PSA does not go to less than 4. Median survival, 13 months. They do worse than patients in castrate-resistant prostate cancer trials. Patients that have a PSA that essentially goes to 0 here, they actually do much better. Median overall survival, 75 months. And then in between, about 44 months. So what in this study we did was we took these 2 groups of patients and we filleted out these because we wanted patients who were truly hormone sensitive. The patients in this group are probably intrinsically castrate resistant, hormone resistant from the get-go, and we didn't think it was fair to do intermittent therapy in them. So basically the patients in the good group who were responding, at least biochemically, got to go on. So the criteria I've already talked about a little bit. Newly diagnosed, they're allowed to have some exposure of neoadjuvant or adjuvant therapy, performance status had to be reasonable, and they had to sign the consent. The consolidation, randomization, and stratification involve looking at the patients between months 6 and 7. They had to be stable at that point, and they were then selected for criteria from the beginning based on performance status and whether they had minimal or extensive disease. And I have a schematic that illustrates this in just a second, which hopefully will come up as we move ahead. This was a non-inferiority study. So we set out to try and prove that intermittent androgen deprivation was non-inferior in terms of overall survival. We were not looking for one actual side to be better than the other. We just wanted to make sure that if we were doing intermittent therapy, it was not likely to be worse. In addition, there were co-primary endpoints of quality of life with 3 specific symptoms: physical and emotional functioning assessment, and also sexual functioning between the arms. And I'll look at that in just a second. And then the patients were stratified based on the factors. So what's the difference between extensive and minimal disease? Well, you can see that this patient over here with minimal disease has a few bone metastases and some lymph nodes. So from that perspective, compared to this patient who has multiple metastases, also can have lung and liver metastases, this is more extensive. Now, what is this definition derived from? It was derived from the prior 2 studies that SWOG did in the 1980s, where they demonstrated that if you divided these patients up, that in actual fact the extensive disease group did worse. And this is difficult because these studies were done largely before we had PSA as a tool. So this was a stratification factor. It's a little complex, but as you can see, it ends up being quite important. So over the course of the study, which ran for 13 years, started in 95 and ended in 2008, we looked at 3,000 patients. There was some ineligibility, and eventually, after excluding the patients who didn't respond, you can see here almost 800 patients went on in each arm with a randomization. And the reason it's not exactly equal is that we needed to even this up for the stratification factors. These guys were 70 years old when they entered step 2 and reasonably well balanced for a variety of factors: PSA performance status, disease extent, whether extensive or minimal, distribution of visceral disease if they had it, prior exposure, bone pain, and also Gleason score where we had it. A lot of these patients did not have tissue available to make the Gleason score. Was there a difference in toxicity between the two? Well, we were concerned about cardiovascular toxicity being different. Certainly that didn't play out, and in fact all the others are fairly much line ball. So there was no particular toxicity issue between the 2 arms. How long did the patients stay off therapy who had intermittent? Well, as we would predict, the median time on study, 100% here, 17 months for continuous androgen deprivation. And in the groups for all patients, whether extensive or minimal disease, it's about 50%. So you get a 50% reduction in exposure to hormone therapy if you do intermittent. What about the survival data? Well, in actual fact, if we look at the overall by arm, you can see here the curves perhaps a little bit apart. The median not terribly impressive, but continuous doing better, if anything, than intermittent. And importantly, we set a barrier of 20%. So in other words, if this error here, the confidence interval had been upper bounds 1.20 or less, we would have said, you know, within a 20% error bound, these are equivalent. But this fits criteria for us rejecting the hypothesis and saying that overall, intermittent therapy is not inferior. Does that mean it's inferior? I don't know, but that's how we set up the study at the beginning. It gets worse, folks. If we split the patients up based on minimal disease and extensive disease, intermittent therapy appears worse in patients with minimal disease. So the less disease, patients need to have continuous androgen deprivation. So in picking a horse, this is exactly what I thought wouldn't happen. If we look at the extensive disease patients, it doesn't seem to make any difference, and in fact this is within the error bounds of 20%. So for your patients that have got metastases in their liver and all over their skeleton, you can give them intermittent therapy and it looks like it's not inferior. All right, so you can do that. For the patients with less disease, in actual fact, you need to put them on continuous androgen deprivation. So we asked the question, does their response based on PSA initially predict how they're subsequently going to do with intermittent therapy? Because you expect someone who was responding to actually do well with intermittent treatment if you re-challenge them. It makes no difference. So I would have predicted a patient whose PSA went to 0 that I could treat with intermittent therapy, and from that perspective, I was wrong. I would have thought that extensive disease patients would have done worse with intermittent therapy. I was wrong. And I would have thought that patients with minimal disease would have done better with intermittent therapy, and I was wrong. So, as my PhD supervisor used to say, counterintuitive results are sometimes the most interesting. And we did some analyses to look at response, whether they had pain, all that sort of stuff. It did not seem to pan out. So there's no way, apart from the minimal and extensive disease criteria, of predicting whether patients will respond to this or not. And the cause of death in each arm, we've seen this before. If you give continuous, they're less likely to die of prostate cancer, more likely to die of other things, often cardiovascular disease. Intermittent, more likely to die of prostate cancer, less likely to die of other things. So you're kind of switching it up. So the conclusions here, essentially, I've already summarised. The study did not satisfy the hypothesis that we started with of demonstrating that intermittent therapy was non-inferior to continuous. In extensive disease, it doesn't seem to make any difference, but in minimal disease patients, they actually do worse with intermittent therapy. There was no treatment interaction, and it suggests there's a biology of disease based on that initial classification we just thoroughly don't understand, but we're going to try and dissect it to work it out. So you all saw the Japanese sumo wrestler who tried out for the ski team. I won't tell you about the landing, but sometimes we have changes happening to men's bodies that they don't like, nor do they understand, especially when they go on hormone therapy. So what was the quality of life here? And this was hidden in a poster, which never actually got posted because it got lost by FedEx, but it's online. And all of the quality of life parameters favour intermittent, all of them. Okay, so this confuses us even more. So that you can say to a patient with minimal disease, okay, buddy, you're going to live 1.5 years, 2 years less, but your quality of life will be less. Sorry, your quality of life will be better. Okay. And so what actually happens when you're in practice? I can tell you what happens. The wife says, you're not checking out 1.5 years or 2 years early. And, you know, I don't care about our sex life. That's normally what happens, not always. So it's kind of an interesting discussion, but this discussion didn't occur before because we think it's as good and, you know, your quality of life will be better. Now, sometimes the guy says, well, I care about sex. By the way, I've got a girlfriend, as well as the wife. Or, it's a joke, but I work in Los Angeles. They'll say, look, my quality of life involves my mental functioning, and when you take my testosterone away, my brain doesn't work. Therefore, I'm going to make the choice to do intermittent therapy, and I don't care whether I'm going to die a little earlier. The other factor here is we have lots of new stuff to treat patients with, and we don't know what the impact's going to be because this study was pretty much complete before we started playing with those things. So the study raises a lot of questions, and it's changed my practice several times. And I'm now talking to patients and providing information and giving them the choice, which is not always that easy. So multiple conundra here summarised in this particular slide. If intermittent androgen deprivation therapy in particular groups produces an up to 2-year poorer survival, I think that's something we need to talk about. The PSA nadir, as I said, predicts survival for the patients, particularly those in the group that don't get lower than 4, but it doesn't help you with your therapy. Okay, now I'm going to move on to something else I don't understand, that's immunotherapy. And this is a T-cell kissing and antigen presenting cell, which I do understand because I trained in some immunology. You've seen this study before. It's the IMPACT study presented several years ago. Sipuleucel-T is somewhat controversial, and picking the patients to give it to is an issue. And our bias, certainly in our practice, has been if we're going to do it, we're going to do it early. and there was an overall survival advantage in the study from 2010. So what's the new data? Well, they went back and analysed the data based on PSA quartiles, and they cut the patients. Now, the median PSA for people going on to the IMPACT study and early castrate-resistant disease happened to be roughly 50. The lowest quartile, less than 22, the highest, greater than 134. And you can see here, as the PSA goes up in quartiles, the survivals go down. So you can see here 43 for the patient getting CYP-T, 41.3 months, CYP-T less than 22. It goes down to 18 when it's more than 134. And also in the control arm, 28 down to 15. So PSA is prognostic, as are a number of other things. But the issue here is not that. The median overall survival benefit was about 4 months. If you treat earlier based on this post hoc analysis, the patients with the lower tumour burden, lower PSA, had a difference of 13 months, as opposed to 2.8 months for the patients with a higher PSA. So what does this mean? Well, when I'm looking at a patient, if I want to do immunotherapy with them in their lifetime, I want to treat the patient when they're here, not when they're here, because I think the benefit, if you go and talk to the chattering class of Houston at dinner tonight, and you say, I've got a therapy that costs X amount of dollars, $93,000, whatever it is, and it improves survival by 4 months, and I'll move on to the next topic, you get ignored, right? If you ask them what would be reasonable, most of them would say, look, if you improve things by a year, that's reasonable. And I think that the better therapeutics with this agent are actually giving it early and not waiting to try and salvage patients. Now, I asked Arnold Schwarzenegger what he thought about Sipuleucel-T, and he said, let's go onto the balcony and smoke a stogie. That's what he used to say when he was governor, because they had to change the rules about him smoking outside when he was there. But the androgen receptor has been productive somewhat for Arnold, although it's got him in trouble. But in looking at other things, we've developed a couple of new drugs, and you know about these. One is Abiraterone, our first androgen biosynthesis inhibitor. The other is Medivation, our first second-generation androgen receptor antagonist. I encourage you to think about these as classes of drugs. Abiraterone is the first of a class. TAC 700 is not far behind. There will be other drugs. And for Medivation, we're already seeing a compound called ARN 509 that could be another one. So these are drug classes, and I think importantly thought about that as such. Cougar 301 demonstrated in a study that was post-docetaxel that there was a significant overall survival advantage and improvement in quality of life for Abiraterone, and this is now approved in the post-docetaxel setting. We got data on Cougar 302, a pre-docetaxel study done in patients with minimally symptomatic disease, not on opioids, similar to the IMPACT trial. And this is the design of the study. It was a 1-to-1 randomization, a little different to the 301, which was 2-to-1. About 1,000 patients, nicely powered, and 2 co-primary endpoints. They actually took a model that I developed for a docetaxel study we did in SWOG, looking at radiological progression-free survival by central review, accepted by the FDA, and overall survival, also accepted by the FDA, and some other secondary secondary endpoints. And they defined progression, adapted from consensus criteria by bone scan as new lesions. They were trying to avoid flare. They got a blinded radiologist in a central facility to look at the scans and determine whether the patients had developed 2 new bone lesions, and they required confirmation within 12 weeks because you can get flare, and you can get flare up to 6 months with Abiraterone of these new drugs. Progression in terms of soft tissue was by CT or MRI, and death from any cause by definition. The patients were well balanced across arms. So there was no issue there, and in fact they were matched for many of these factors. The progression-free survival here is impressive. The only problem they have is that the AA arm, which is the top, did not actually hit 50%, so it hasn't hit its median yet. But the median progression-free survival for prednisone in this group was 8.3 months, hazard ratio 0.43. and a very significant p-value. And so they'll follow this further, but you can see the patients are out now at 18 months and they haven't hit the median, although they're close. So this is very, very significant. And if we look at a forest plot, and some of these things have sort of dropped off, virtually all of the patients, regardless of group, seem to get that benefit. The overall survival data are controversial. And the big problem here is good news for patients, bad news for trial design guys like me. The patients actually were living a long time on abiraterone and prednisone. And you can see once again here at extended follow-up, the prednisone group have just hit their median OS at 27 months. And the abiraterone patients are not near that, although we don't know what's going to happen with the curve. And so what the Data Safety Monitoring Committee said was, you've got to stop this study. There's so much benefit based on PFS, and there's a really strong trend. Now, it did not hit the O'Brien-Fleming boundary, which is down here of 0.008. It's only 0.0097. But Susan Alabi reviewed this at ASCO, and essentially there's about a 94% chance that OS is improved with abiraterone, and I think that's actually significant, and I think that when this goes to ODAC, it will be approved based on that if the FDA wants to do that. Serologic and clinical responses were significant. PSA decline in about 60% of patients, so not everybody, and benefit from the drug tends to be independent of whether they have a significant PSA decline. You have patients that have slow rise with no progression for up to a year. So don't be too hurried about taking a patient off if they've just got a slow PSA rise. There were delays in time to opioids, to chemotherapy, and PSA and ECOG parameters, and we'll get some more data on that subsequently. So the Data Safety Monitoring Committee unblinded the study and actually crossed the patients over, and I think that was the right thing to do. And so we have delay in disease progression, increased survival that may not quite be statistically significant yet symptomatic, delay in symptomatic issues, and there are no new safety issues really to report. The other drug that we saw initially at GU ASCO in February was reported in follow-up, and this is MDV-3100, now called enzalutamide, and classified as part of the same group as flutamide, bicalutamide and ilutamide, but with much more efficacy and demonstrated overall survival benefit, as you'll see here. So this is a drug that's novel, was developed by remodeling bicalutamide so that it blocked the androgen receptor irreversibly, was not prone to variation based on mutations in the androgen receptor, and stopped the androgen receptor from going into the nucleus, and so was felt to be much more effective. This was developed by Charles Sawyers at UCLA before he moved to Memorial Sloan Kettering. So in this study, the AFFIRM study, these were patients who'd had docetaxel and progressed. They were randomized 2-to-1, almost 1,200 patients. Primary endpoint was overall survival, and there are also some other things we'll see. This is an impressive drug. The hazard ratio is 0.63. The difference in median survival is 4.8 months, and it produces significant PSA responses, as I think we'll see in a moment. So half the patients had a significant PSA decline, and there was delay in both biochemical and radiological progression with the drug. The adverse events were not significant, although there were a few seizures that occurred in patients on Medivation, and if we look at those, there seem to be maybe predisposing things like brain metastases and intravenous lidocaine in that group, but that's something to look out for, and if you've got someone who is an epileptic, it may be an issue to discuss with them before you want to start this drug, and this will be followed closely after registration, which I think will be soon. So what does all that mean? Well, I think abiraterone's got clinical activity in the pre-docetaxel space in early castrate-resistant disease. It'll get approved, but I think it's going to go to ODAC to have a group of peers look at it. Medivation 3100 is a powerful drug that has some strange effects on lymph nodes. So you can get in a patient who's having a great PSA response a flare where they seem to have new bone mets, on technetium scan and also sodium fluoride, but lymph nodes sometimes swell up a bit. And the radiologists say, this is 3 millimeters bigger and there's a flare, patient progressing. You're looking at the patient, their pain's gone away, and they're really doing very well. They're off all opioids. Just wait with that patient, because Medivation 3100 produces major apoptosis as part of its mechanism that we don't see with Abiraterone in the lab. Abiraterone usually ticks the proliferation down, and so there's some sort of immune effect that this drug has that we don't understand yet, and we're trying to work out. It'll get approved by the FDA. They just got accelerated approval confirmation, and we may actually have it soon. It'll be a challenge for a new company to roll it out, and we're waiting for the pre-docetaxel data with this drug, which has completed accrual, and probably will take another year. Okay, so some more stuff, folks, and sorry there's so much for prostate. And I'm going to talk about radium-223, an agent that Stan Nilsson developed with the Norwegian Radium Institute over about a decade. Now, the things that are absorbed into bone on the periodic table are over here. You know them: calcium, strontium, barium, and this is radium. So it's part of the same deal. Now, we don't give barium intravenously because it sludges up the vessels. And it's difficult to get soluble, but we do swallow it, and it's radio-opaque at times. So these things naturally go to the growth areas of bone, particularly around bone metastases. And radium-223 is excreted by the small intestine. It goes out through the stool fairly quickly. The way this links in to the milieu is it hits at the bone marrow bone interface where the tumour is, and it has a very high dose alpha particle irradiation that has a very short area of irradiation, but at relatively high dose compared to beta emitters, which we've used otherwise. The other advantage of alpha particles is they produce double-stranded DNA breaks in the tumour cells, which are more likely to be lethal to those tumour cells. So this looked like a good therapeutic, and I had dinner in Oslo with Stan Nilsson in 2004, and he showed me the data from some animals in phase 1 and said, do you think it's worthwhile doing? And I said, yeah. So this is the phase 3 study that was predominantly conducted in Europe, where they took patients who had either had docetaxel or declined it. They were ineligible or refused. 900 patients, 2-to-1 randomization. The patients could get best supportive care, including radiation therapy to bony soft tissue, bone or soft tissue lesions that were symptomatic, bisphosphonates, and secondary hormonal therapy with standard sort of things. The patients treated got 6 injections a month apart, and best supportive care versus placebo infusions in the study. Primary endpoint, overall survival. The patients were very well balanced for these known factors, including PSA and bisphosphonate use. And the interesting thing was that in a very early analysis that we saw a significant overall survival. This surprised us. We thought it was going to take some time. And once again, a very impressive hazard ratio with an improvement in overall survival of about 3.6 months. And so this looks like it could be an alternative to docetaxel. And I'm going to actually flick through the rest of this rather quickly, because I do just want to say something briefly about renal cell. And just to comment, we don't see a lot of thrombocytopenia with this, so this is not strontium and not even samarium in terms of toxicity, and the other toxicities are fairly mild. And so the analysis conclusions were that it improved median OS by 3.6 months and also delayed skeletally related events by the definition in the study. And this will be rolled out with your nuclear medicine or radiation oncology colleagues. This is a novel agent. It's going to be an alternative to docetaxel afterwards. It'll get approved, and then the issue with this is that bone markers predict response, particularly alkaline phosphatase, but less so PSA. And so our algorithm for treating patients based on NCCN guidelines is going to change. In fact, this is already out of date. We have the version 4, where they're actually, they've brought radium-223 up a level to make it level 1, and also Abiraterone to level 1. So just to make the point that in 2004-2009, this is with the discussion of treatment for castrate-resistant prostate cancer. We want to protect the bone, calcium, vitamin D, an osteoclast inhibitor, zoledronic acid, secondary hormone manoeuvres, docetaxel, mitoxantrone. What have we got now? Well, pick a winner, folks. And we've got a lot more therapeutics to deal with. We have denosumab in this space. We've got Abiraterone, Sip-T, radium-223, cabazitaxel, Medivation 3100 down here. So from that perspective, it gets a lot more complicated, and there's going to be some challenges for us. These are good things for the patient. So just in terms of our new systemic therapy for advanced prostate cancer, we have 4 new therapeutic classes. Not just new therapeutics, new therapeutic classes. And so we have a challenge of fitting immunotherapy, androgen biosynthesis inhibitors, second generation AR antagonists, and bone-targeted radium. And our real future challenge is this, sequencing and combination of the therapies, moving the new therapies earlier in prostate cancer, and then trying to look at new targeted treatments. Cabozantinib targets c-Met, which seems to be important in bone. And then the bottom line is, can we do it cost effectively, which is a big challenge.